All right, we're going to go ahead and get started. So thank you all again for joining us for the last webinar of the year for Austin ISD. For those of you who are unfamiliar, my name is Christopher Jammer, and today we have with us Dr. Rachel Westbrook, one of our providers at our Red River office. As you guys all seen, just to go over some housekeeping items before we get into the actual content of the presentation. Of course, all your microphones are muted, and that is so that myself and Dr. Westbrook can get you the information as quickly and as efficiently as possible. If you have any questions about any of the content as we go through the presentation, feel free to utilize the Zoom chat function to send those over to us. If you have a really specific question that you would like to ask Dr. Westbrook or myself, and you're not necessarily comfortable with asking it on a virtual platform, we also offer these things what we call virtual injury and pain chats, where you can literally scan the QR code and set up a time and date that works a little bit more efficiently for you to ask those questions to one of our doctors. And as we go through the presentation, this QR code will be strategically put on different ones of the slides, so you guys will have multiple opportunities to access those VIP chats. So for those of you who might be unfamiliar, we are a healthcare provider group that specializes in treating soft tissue injuries, literally anything from head to your toes, as long as it's not a fracture, a broken bone, or a full thickness tear that's going to require surgery. It's going to be something that's within our wheelhouse. And generally, outside of treating these particular injuries that come into our offices, we like to do what we call preventative and proactive wellness talks to talk about some of the conditions we see to help you guys be able to identify some different things you might be dealing with and be able to proactively combat those symptoms and conditions that you may be dealing with on a daily basis at home, in the gym, and things of that sort. So today we're going to talk specifically about some issues that a lot of runners and walkers may come into contact with. So without further ado, I'm going to turn it over to Dr. Westbrook to take you through the presentation.
Unmute. Perfect. All right. So hi, everybody. I'm Dr. Westbrook. I'm not sure if I've done one specifically with this group before, but I have done this running prevention seminar a few times, and it's quite helpful. So if any of you are existing runners, existing walkers, or if you are trying to get into a healthier habit, especially it's about to be the new year, people start setting those resolutions. And we can really get ahead of a lot of injuries that are very common with walking and running before they ever start. So that's our goal here today. So we're going to first go over different types of common injuries. Most of them are going to be lower extremity. And this can be a little bit repetitive because a lot of these issues are overuse issues. So, but we'll go over some common running injuries and then also a couple things that you can do to help prevent them or get ahead of any nagging pain. And then of course, if you guys have any questions, you can put them in the chat just like Chris said, and we'll get to those too. So let's get us started.
So before we move on, Dr. Westbrook, I'm sorry I meant to mention this before. So for everyone who's on the call, of course, if you can, just to make sure that we get your wellness credit over to the Austin ISD wellness managers, could you all send me your first name, last name, and your employee ID number so I can get that recorded for you all? Thanks.
Get those points, guys. Alrighty, so common walking and running injuries. Again, most of them are for the most part lower extremity, and a lot of them are very related to each other. And you can also have one in some. You can like plantar fasciitis and Achilles tendinitis. They're very closely related. But we'll start out with good old plantar fasciitis because I see that a lot. I see that a lot in just general populations. Whether you sit or run, this one can really kind of hit anybody. But we'll go to the plantar fasciitis tab. Perfect. Okay, so the plantar fascia, it is a big, thick, like think of the plantar fascia. It runs along the bottom of your foot and it's kind of highlighted in orange there. It connects your heel to your toes and it helps to support the arch of your foot. That's really important as far as maintaining that arch to help prevent any collapsing arch, which can cause foot pain, heel pain. Oh, I've done something to my view here. Okay, there we go. Sorry. Foot pain, heel pain. A lot of times it'll start Sorry, I'm going to try and get my view. I need to be able to see myself so I can make sure. Okay, there we go. Okay, so if this is your heel, the very bottom of your heel here, so here's your foot on the floor, that plantar fascia connects from that calcaneus bone, so that's the actual heel bone, up to the toes, and it basically helps to create this nice arch in your foot that is it's a spring. So if you weren't to have an arch on your foot, like we'd all be just like flapping around like ducks, and we wouldn't be able to do any kind of high impact exercise. Think of this as a piece of duct tape. It's not very flexible. It shouldn't be flexible. And if it's flexible, suddenly we have some problems. But it's our main shock absorber, as this says. Plantar fasciitis usually starts out, again, very tip of the heel. So usually it starts kind of in this general spot. So this is the actual insertion point of your plantar fascia. Sometimes it'll be smack in the middle of the heel. I even have patients where it kind of wraps around in like a little kind of saddle shape around the heel. So it can kind of present in different places in different ways. Most of the time, plantar fasciitis, kind of classic plantar fasciitis, is those first few steps in the morning. You kind of go, ooh, ah, ee, ooh, ah, or if you have to kind of get up in the middle of the night to pee, that's usually the most painful part of plantar fasciitis. If you've been sitting for a while and you get up and start to walk around, it'll be really intense at first, and then it'll kind of stop or maybe even go away, and you might not have pain throughout the day. But if you kind of just kind of ignore those first few steps in the morning and you just go, so whatever, it's fine, there's a good chance that it's going to kind of spiral out of control, and you'll start to develop pain more with sitting. A lot of my plantar fasciitis patients will say, oh, it just throbs even when I'm sitting. It'll start to hurt more as you walk. It can start to spread up into the Achilles. Activity is usually something that will aggravate it. Like I said, sometimes you won't even have pain with running, but if you go on a run and then you sit down, drink your coffee, eat your cereal, and then you get up to go get dressed for work, that might be really painful to get up and start walking around after a run. Being barefoot, harder surfaces can really also aggravate this. And the causes are a couple different things. So foot biometrics. Biometrics is just the fancy medical term of like how your bony anatomy is formed. And there is a question, is a plantar wart related? No, those can be quite painful though. And that is going to be more of a podiatrist situation where they'll do some kind of wart treatment. But you can have a plantar wart and plantar fasciitis at the same time, but they're not usually related. The wart's more of a virus that's dormant in pretty much everybody. Thank you, high school gym class. But the foot biometrics, that is, again, the kind of bony shape of your foot. So that's really more genetic, how you developed as you were a kid, your mom and dad, if they have a funky foot, maybe you got a little funky foot. That's something that we can change. Sudden increase in mileage. So if you have never run a marathon before, I cannot recommend you go out and run a marathon tomorrow, because your muscle and your tissues and your tendons are not strong enough to support that kind of load under that kind of distance. So if you start a training program, if you've never run before, you really need to start out very gradually and ease into longer distances or faster speeds. Because if you're just going to sit there and go straight out the gates with no training, that's definitely signing you up for some plantar fasciitis. Shoes that don't offer support. So, and this can be kind of debated in the physical therapy world, but if there was a big trend maybe 3-4 years ago with a barefoot running, maybe even longer ago than that, or a zero drop shoe, a negative drop shoe, that means that the like space, the distance of the heel is the same as the toe box too. So there's no incline at all, which that for some people, that's totally fine. That's something that you typically have to kind of ease yourself into. But if you also are trying to run in your chucks, not the best. You want a little bit more arch support, but a poorly fitted shoe, or if you've been pregnant, your feet do grow. And then if your shoes are too small, your foot's not going to move in them properly. They're not going to spread properly. And that can lead to some biomechanical issues that can lead to plantar fasciitis. So going to get a shoe properly fitted, there's a couple places in Austin that do a really good job. You let me know, I'll put that in the chat box too. And then bad biomechanics. And the thing with biomechanics is with the foot, a lot of the biomechanics are actually controlled through our hips and pelvis. If you have a weakness in a hip flexor, in your glute medius, that is going to lead, and it's going to kind of trickle down through that kinetic chain through your knees, and the pain can actually start in the foot when really the dysfunction is actually up in your hip and pelvis. So biomechanics, and we'll talk about that in a moment too, but that's going to be a big trend. You're going to see sudden increase in miles and bad biomechanics on pretty much all of these slides here. So we'll go to the next one. Okay, yes, Achilles tendinitis. So I call plantar fasciitis and Achilles tendinitis, they're half siblings. Very similar issue, just slightly different location, but your Achilles actually does sort of connect into your plantar fascia as well. They're still part of that entire kinetic chain. So the Achilles, fun fact, it is the largest tendon in the body, and it's actually made up of 3 different muscles. One is called the plantars. We don't, you don't need to know. I'm not going to kind of quiz you about that one, but there's 2 other muscles that form your Achilles tendon. One is called the gastrocnemius, and I like to call that the big sexy. That's the one on the outside. You can really see it good. It's got 2 lobes. That's your gastrocnemius. But if I were to cut this muscle away and then kind of flip it down or peel it up, there'd be another one under that called your soleus. And both of those are really important in ankle stability and also being able to propel you forward. These tend to get really, really tight in people who wear, like, even if you wear like a little kitten heel all day long or high heels all day long, if you're walking up on your toes for your job or, you know, whatever, or for style, that Achilles is already being shortened. And then so suddenly when you try to run, nobody should be running in heels. It's only for the movies. Suddenly that shortened Achilles that was here now has to operate here. And it's already been shortened. It doesn't like being stretched out. And so a lot of the Achilles pain is also like a lot of Achilles tendinitis will be here, but sometimes it's really just right where it inserts on the bone. So it's kind of similar to plantar fasciitis in that way, where it's also usually those first few steps, you're like, ooh, ah, ee, ah, and then it'll kind of warm up. And then if you go on a run and then sit and then try and walk again, it's going to be really painful after any kind of period of rest. And then again, usually at the end of the day, repetitive stress, again, running, wearing high heels can kind of contribute to this. If you do a lot of like inclines and declines, this can also be an issue here, especially in Austin. I would think that just a guess here, but my colleagues in our Houston offices where it's really flat, they probably see less Achilles tendinitis and less patellar tendinitis than us Austin doctors do, because there is some incline in this area, whereas Houston is just very, very flat. Again, proper form, bad biomechanics, really weak hip flexors is a big cause for this one. Again, you wouldn't think so, but I always test hip flexors out with my Achilles tendinitis patients. So symptoms, mild ache or tenderness, sharp pain with walking, running. You might even see some swelling, worse in the mornings or after a period of rest. Those 2 muscles I was talking about, the gastrocnemius and the soleus, if you can stretch those out before you ever even have pain, keep that tendon nice and long, that can really help a lot to prevent that. A naturally flat arch. So again, that biometrics, like I personally, I just don't have much of an arch at all. And so I'm more prone to plantar fasciitis and Achilles tendinitis. People with really, really, really high arches can also be more prone to plantar fasciitis, but not so much with the Achilles tendinitis. Higher archers tend to have less Achilles, but they can end up with some plantar fasciitis. And again, hilly terrain, just like I said, going uphill is actually, like, physically and mentally, we think it's harder, but going downhill is actually harder physically on our body. And so that's kind of an interesting catch-22, because you're like, oh, I hate going up this dang hill, because cardiovascularly it is harder, but going downhill is harder on your tendons and your muscles. So it can contribute to some extra fun stuff there. All right, shin splints. Okay, so shin splints, I'm sure everybody has known somebody or has had them themselves. The technical, if we're going to get nitpicky and, you know, testing on my board level stuff, a shin splint is really an irritation of a membrane. We call it the interosseous membrane. Do I have a picture of one here? I might, but essentially, okay, well, this is close enough. So this is actually an arm. I'm not sure you could tell, but you have similar bones. You have two bones in your lower leg, your tibia and your fibula. In our arm, it's called the the ulna and the radius. But in between these bones, you have this kind of fibrous connective tissue called an interosseous membrane. You have that in your lower leg too. And a true shin splint is irritation of that membrane, or if you've ever heard of a high ankle sprain, same structure, different issue. But a lot of people will come in saying, oh, I've got shin splints, when really it's in the front of their shin, or maybe even kind of to the side right here. And those are actually tendinitis type of injuries, but we call them shin splints just because it seems to fit pretty well. But there are three muscle groups that we really kind of consider candidates for shin splint diagnosis. The two main ones are, I would say the most common one is the tibialis anterior that I see. Second most common would be the tibialis posterior, which that also can lead to some plantar fasciitis too. So that's kind of a fun one. And then the peroneus muscle group, that one is more on the outside of your leg. And that one's probably about equal with the posterior, the tibialis posterior. And again, causes, bad biomechanics, bad shoes, overtraining. This is more common if anybody's ever heard of like overpronation or oversupination in your foot. If you tend to kind of run or walk on the inside of your foot, that's more of that's called overpronation. If you're walking more on the outside of your foot, which is less common, that's called oversupination. Other things that can lead to shin splints is a lack of dorsiflexion. So when I say dorsiflexion, here's the bottom of my foot, here's the top of my foot, that's your ability to pick your toe up. You really need to be able to go a little past 90 degrees when especially if you're going to run or do a lot of squats, those sort of things. And if you've ever twisted your ankle, and Lord knows we've all twisted our ankles before, it's kind of the favorite thing we do when we play soccer and sports, that can really prevent proper amounts of dorsiflexion from happening. And if you can't fully pick that toe up, because again, there's a ligament that'll kind of get crunchy and bunched up that'll prevent that, suddenly you'll start picking your feet up in a weird way, essentially so that you don't trip. And that's really where we see shin splints develop, is if there's not enough dorsiflexion, you end up overusing some muscles trying not to trip over your own feet. And that's where shin splints come into play. Again, weakness in your glutes as well can lead to this. If you were that weird person who've never really had an ankle sprain, you probably got weak glutes or weak hip flexors, specifically your glute medius, which your glute medius sits right here. Kind of think back pocket, think haunch. And that's a really big muscle for any of my runners, because that's going to stabilize you from side to side. If you tend to have a hip drop, so if you're running, and I know it's kind of weird, I like to watch people because I just know my biomechanics, but if you ever watch somebody, you're walking at the mall or running on the trail, you might notice, get some contrast, you might notice that one of their hips just kind of dips down with every step where their other one really doesn't. That's a good sign that the opposite glute is weak. And they are signing themselves up again for plantar fasciitis is a big one there. Any kind of shin splints, knee pain with the glute medius, and I think we'll probably talk about that in a minute. But that can lead to a lot of lower leg issues in general, is that glute medius. All right, so IT band, everybody's favorite thing to roll. And this is another one of those issues that there's a little bit of a debate going on in the medical community, and I'll let you know my opinion on that. But fun fact about the IT band is the Achilles tendon is the largest and the thickest and strongest tendon in our body. Your IT band is actually the longest. So it's another kind of I think the IT band and the plantar fascia are kind of similar in that it's really rigid and it doesn't stretch a whole lot. We don't really want our IT band to stretch because it is a big stabilizer for our knee. So any of my patients that have maybe even plantar fasciitis, but any kind of knee pain, whether it's on the outside or the inside of the knee, and they go, oh, my IT band is super tight. Your IT band should be tight. We want it to be tight, but what we do not want is a muscle that's very top of the hip, kind of in the front. If you find the bony part of your hip in the front, and then you go just to the outside, That's a muscle called your tensor fascia lata. It is a stinker and it causes a lot of tugging and pulling on that IT band when it's too tight, which can really irritate your knee. This TFL, because tensor fascia lata is Latin and it's hard to pronounce, your TFL will get really tight and short if you sit for your job a lot. So I don't have this issue because I'm up and down on my feet, but your hip flexor and your TFL will just start to tighten up and it learns how to be tight. If you're sitting for 8 hours, that muscle is shortened and it will learn how to stay short. And so getting a stand desk, trying to stand every 20 minutes or so can really go a long way for some of these knee pain issues. And then really digging in with like a lacrosse ball and releasing that TFL can help release the IT band. Some people say, oh, it really hurts when I roll my IT band. It's okay to roll on your IT band, but it's not going to be super productive. When you roll your IT band, you really kind of want to be more on the front side of your IT band and the back side of your IT band, just to kind of break it away from the hamstring and the quad so that it kind of moves and glides a little bit more. But to say, oh, I'm going to stretch my IT band out, you're really not stretching your IT band. You don't necessarily want it to, but your IT band should move nicely. IT band, the iliotibial band syndrome, that might kind of ring a bell for some of you guys. Patellar tracking, those are all kind of, again, like kind of sort of an umbrella diagnosis for knee pain. A lot of times it's going to be either kind of like people sort of do this little swoopy motion so that there's a little bit of pain in the front of the knee, maybe it's on the side. But those are runner's knees, super common again, especially in a hillier terrain, or if you're also running on the street. My long distance runners, sometimes Town Lake just isn't far enough for them, Lord have mercy. And so, you know, all roads are kind of dome shaped vaguely. And if you're running on the road, and we are supposed to run against the flow of traffic legally, right? So you end up always running on the left side of the road, which puts your left hip down and your right hip up. And so you kind of end up running with your hip in this cattywampus position. That can lead to a lot of IT band issues in either knee, kind of again, depending on your own biomechanics. It can become very, very, very painful to the point where walking or going up and down stairs can really be irritating after a run. And again, a broken record a little bit here, overtraining, you can't just go and say, I'm gonna go run a half marathon, even though the furthest I've ever done is 2 miles. Poor form, hip mobility, hip weakness. We do a lot of hip stretches with IT band and knee issues. And then of course that weak glute medius muscle. The reason the glute medius muscle is really a big player in the IT band issue is because that tensor fascia lata that I mentioned, its job is to abduct your leg. So it's going to be helping to bring this leg out. However, this muscle is pretty small. This one is pretty big, but this one gets really weak. We sit all day. Our glutes don't work when we're in this position, but this is starting to tighten up here. And so if you're running and you do sit a lot, this is weak. This will become very strong. And again, it's just going to start overloading that IT band and really pulling at the knee. And so strengthening those glutes up, doing a lot of clamshells can basically kind of reprogram your hip. It's going to reprogram your butt and it's going to say, hey, use this muscle, not this muscle. And so you can kind of really retrain things so that neurologically your brain is using the right muscle while you run. That will help just kind of take all the pressure off of that IT band and therefore off your knee. All right, so prevention strategies. I've been kind of sprinkling these in a little bit, but we'll get a little bit more specific. So, and these are things that we teach our patients in clinic. So if you do have pain, I highly encourage you to make an appointment. We'll at least take a look at it. But this is sort of the key to really healing yourself is mobility, stretching, and strengthening. All right, and so the mobility, that's going to be your lacrosse ball and your foam roller work. Again, everybody's favorite here, but foam rolling through the calf, that's going to really help with your Achilles tendinitis, your plantar fasciitis, although I really recommend anybody who runs regularly to do all of these 2-3 times a week, depending on your mileage, even if you don't have any of these issues. But the calf's going to really be a big one in the plantar fasciitis and the Achilles tendinitis. This next one in the corner, that's that IT band rolling. And this is this angle probably doesn't do it justice, because you can kind of maybe tell he's really more kind of like IT band quad, and really staying up near the hip is going to be more productive. But that's going to be a big one for your, again, the IT band, any kind of knee issue. If you've got some of the peroneal tendinitis, which falls under the Shin Splint umbrella, that's going to be a big one. The glute foam rolling, again, that one's kind of one of everybody's favorites. I would say the IT band and the glute, I've never once met a person who this isn't tender on. The calf, you know, depending on your activities and how your foot and your, you know, your hamstring strength, things like that, the calf might not really be super tender on you, but $20 says that the IT band and the glutes will be tender on pretty much everybody. Same thing with the quad. That one can be pretty juicy, especially in runners. But all three of those really, not so much the calf one, but the three, the IT band, the glute, and the quad, those are so important to help your pelvic tilt. So we call it anterior pelvic tilt. I call it J-Lo booty. But this can also, so, you know, your butt sticking out like this, we've got a really bad lumbar lordosis. Really, our pelvis wants to work here. So if you can kind of release the quads, release the IT band, release the glutes, get everything nice and balanced and happy, suddenly your pelvis is put into this neutral position. That's the position and that's the angle that all of your glutes are meant to fire at. So when my butt is sticking out like this, suddenly doing a glute squeeze just doesn't feel quite as productive. But when I put my pelvis back into neutral and I start squeezing my glutes, I get a much more full contraction. So, and you can even stand up and try this. It's kind of interesting. So if you want to, anterior pelvic tilt, J-Lo booty, try to squeeze your butt. It's going to kind of, honestly, it kind of hurts my low back a little bit, and I'm really not squeezing very much. But suddenly when I put my pelvis back into neutral, I can get a really good tight squeeze on both sides, because that's the angle that my glutes want to be able to fire at. And so that's kind of a fun little trick that you can do. The last one, this is just honestly, even if you don't have plantar fasciitis, this one is just a delight. If you do have plantar fasciitis, it can be quite painful, but in a really very productive way. Get that lacrosse ball, take that shoe off while you're sitting on a boring meeting or in between class, and start rolling through that arch. You'll usually find one or two really just juicy spots in there. But that honestly just kind of feels, everybody should do that. It's just nice. And our feet, we really underappreciate our feet. They're pretty, architecturally, our feet are really cool. I'm a nerd. And so you should show your feet some love. All right, so big toe and plantar fascia stretching. So really, again, kind of the debate, are you really stretching your plantar fascia? Are you really stretching your IT band? No, probably not, but you do have muscles underneath your plantar fascia, specifically your flexor hallucis longus. That muscle is the one that helps you to flex your big toe. Another big key player in that arch support, and it can kind of get really overloaded and worked. So you can use a wall, you can use your hand. If you're seated, cross one leg over the other, and then you're gonna pull that big toe up towards your knee, and you should feel a nice stretch in your arch. For me personally, because I am pretty flexible, I can't really do the seated one. It's just not quite enough for me. I also do physical therapy for my job. And if not, and so if doing the seated version doesn't work for you, you're gonna wanna come over to the wall. And if that still isn't giving you a little bit of a stretch in your arch or your big toe, you can even pick your heel up off the ground and get a little bit more mustard in there, and that will usually work pretty well. But this one I give to every single one of my plantar fasciitis patients. Maybe not on the first visit, but once we get the pain under control and I know that we're not gonna piss off that insertion point anymore, this is a big one for prevention and to get that last little bit of pain to go away. If you already have a really bad case of plantar fascia, don't do this, not yet. Please don't do it yet. It will piss it off. You're not really going to damage yourself, but it's going to make it really mad. And that tissue is just not ready for that stretch yet. So if you have an active and flared up case of plantar fasciitis, don't do this one yet. Come to see me first and we'll ease into that. But this is a really good one to prevent too. All right, calf. Okay, so again, just a reminder that your Achilles is formed of 3 muscles. We really only care about 2 of those. That first one is your gastrocnemius. The model here, she is stretching her foot that is behind her. Yes, so when you stretch your gastrocnemius, you're going to keep your knee straight. When you stretch your soleus, which again, that's that muscle that if you cut away that big sexy gastrocnemius, that one's going to be underneath. You're basically same thing. You're going to keep your heel on the ground and try and push your knee into the floor. It's going to kind of change the stretch just a little bit, even though sometimes your knee might not move very much. You might just get a teeny little bend in it and you're going to kind of notice like, oh, that stretch feels, usually it's a little bit lower towards the Achilles for the soleus, and the gastrocnemius is going to be more up towards the knee in the big belly, the bulk portion of your calf. But both are very important. This version, there's actually a second version that I'm going to put my computer down on the ground to show you guys because I like it better. Again, personal opinion, and it's just kind of the way my foot biometrics are. I prefer to use wall for this, and it's going to look the same. This red piece of tape on my floor is a test that I use for all of my Shin Splint patients, my plantar fasciitis patients, anybody with knee pain in the front of their knee. I actually have them, we kind of test your range of motion out with this little piece of red tape, but the stretch, I'm going to keep my knee straight for the first one, and it's just a classic, I don't know, can we see? Yeah, it's just a classic calf stretch. The second version for the soleus, I'm pushing my knee towards the wall. And I'll even kind of show you guys this little test. This is a 6-inch piece of red kinesiology tape that I have marked off in inches. At the 5-inch mark, you should be able to keep your foot on the ground and get your knee to the wall. So this is my good foot, it's my left side. I actually do personally have some like kind of a long history of plantar fascia from a hiking injury. I'm about, I don't know, like maybe an inch away from the wall. I cannot get my right knee onto the wall, again, because of some ankle sprains and some tightness, and that's something that I continue to work on. I don't really have pain anymore, gotten that under control, but you can even see my range of motion somewhat sets me up for failure. If I were to try and go run a whole marathon today, you bet your bottom that my plantar fasciitis is going to come right back. So that's just a different way to stretch those 2 same muscle groups. 6 one way, half a dozen the other. All right, hip glute. So this is another one where you can even kind of look at a test and see on yourself, because most people have one hip that is a lot tighter than the other. Usually it's going to be your dominant side. Everybody's a little different. But if you are, again, seated in a chair, throw one leg up over the other, and you can start to lean forward, and you should feel a good stretch in this haunch here. But again, this might not, we're on Zoom, so it's not ideal, but here is my natural kind of range of motion in my right hip. So my knee pops up to about here. My left, oh, look how flat she is. So you can tell how loose and easy this is on my left side, and my right side, like she just keeps kind of pulling up. So I have to really spend more time stretching my right hip. If you guys see a pattern like that, if you have one side that's a lot tighter than the other, I typically recommend start on your right side, hold this for about, 30 seconds, 90 seconds even, somewhere in between there. Switch to your left side because your left side will get jealous and she needs to be stretched too. But then after another 30 to 90 seconds, switch back, get your tight side again. And that's a pretty good rule of thumb for stretching in general, is that 30-second mark is really kind of the base minimum that you want to do as far as stretching. A lot of my patients are like, oh, well, I do stretch. And I go, cool, how long do you stretch for? And they're like, oh, yep, and there, oh, okay, done. No. Better than nothing, but the studies have shown that if you can hold your stretch for at least 30 seconds, that really has given that tissue some time to relax. Another one is don't stretch right before you go run. You want to do a more ballistic warm-up, something like some jumping jacks, monster walks, those sort of things, but you don't want to just hold a good static stretch until after your workout, because stretching, I also think this is a fun fact, if you stretch a muscle properly, it actually kind of weakens it for a very temporary amount of time, about 2 hours. But neurologically, as we stretch some tissue, we're telling it, hey guy, calm down. You can relax. You can loosen up. You're fine. We're safe. And so if you were to stretch and really hold these stretches before your run, you're actually weakening your muscles, and your muscles need to be strong to help protect your joints and your tendons. So heads up, don't stretch right before you run. All right, and I think, is there one more? Oh yeah, okay. Toe yoga. This one is, honestly, it's just hysterical to me. And I will say the model here, even my feet cannot do it quite that range. I'm not sure who in our company this is, but they've got really great toes, which I guess is maybe a really weird compliment to give somebody. But that range of motion is very impressive. You're probably not going to look like this at first, but essentially what this exercise does is it is training all of these little muscles that sit in between. So again, I'm using my hand as my foot, but in between each of your bones here, you have a series of muscles that help control your foot spread. That's really important when you're running and walking. Again, it's more of an arch support kind of situation here, but all these little muscles that, like, I don't know about you, but I don't think about mine. And so in order to train these muscles and to kind of just get them online and on board for what you're doing, you're going to do toe yoga. Your goal, I start out with just doing my big toe. And so you're going to try to lift just your big toe with leaving all of your other toes on the ground. For some of my patients, I'm going to put my laptop back down. For some of my patients, I literally have them, they can't do it very well. And so I'll have them hold their other toes down, just lift your big toe, and then you might be able to kind of do it a little better after. Once you kind of get the big toe down, then you're going to try and lift all of your other little toes up. All right, let's see what my range looks like. See, I don't really have, she does much better than me. And then if you get really good, you can start alternating. That one, honestly, this can be very challenging even for me. But as I do it, I'm getting better at it right now. You can even see. So as we do this, as we do these exercises, we are reestablishing and re-strengthening all of these mind and body connections so that your brain knows, all right, I'm going to use my interosseous muscle while I'm running so that my arch cannot collapse and I don't put so much stress on my plantar fascia. But I give this exercise to really any runner. On my sock. But especially my plantar fasciitis patients, if you also have pain in the ball of your foot, anywhere kind of in here, that's another, I don't see it as much as plantar fasciitis, but I probably see a couple cases a year. We call that metatarsalgia. There's a couple different causes of it. Metatarsalgia is another kind of like blanket umbrella term for my metatarsals hurt. And that one, I give these toe yogas to all my metatarsalgia patients, my plantar fasciitis patients, any of my patients that I see have a flatter arch like myself. This is going to be really good for you if you naturally just don't have much of an arch, or if you have a really, really high arch. These are going to be really good exercises for you to do. And it's kind of a fun party trick. And you might even notice, I didn't show you my left side because my poor left foot, she does not know what is going on, but it takes me a lot longer to get my left big toe to cooperate and my left right toes to cooperate, because again, I'm very right-handed. And so my left foot is just kind of like, well, we're along for the ride, but she doesn't put as much effort in as my right foot does. So you'll just start to see these little differences from left to right in yourself. And the closer to perfectly symmetrical we can get you, the better you're off. But this is a fun one. Try to teach your kids to do it, because I just enjoy teaching these to my family members, because you will look goofy. Ooh, heel up. Okay, so this is a really great exercise. I like this one because it is calf raise. It's going to strengthen your gastrocnemius, part of your posterior chain. So that's going to help propel you forward a little bit faster. But when you pinch a ball in between your heels while you're doing a calf raise, and you can do this while you're brushing your teeth, anything like that. You don't even need a ball specifically. If you have a sock, anything that's light, pinch it between your heels, between your heel bones, and then your goal is to do a full heel raise or calf raise without letting that ball drop down. That is going to help strengthen your posterior tibialis. So that muscle sits right behind your shin bone. When I treat it, I almost like have to hook underneath. So your posterior tibialis is like behind your shin bone. It swoops down, circles around the bone here, and then inserts about right here in your arch. It's a big arch support muscle. So for, again, my patients that have like very flat feet or very high arches, this is going to be really, really good for you to do, even if you don't have pain, just to help maintain your arch as you age. Or if you get pregnant and your center of gravity changes, or if we eat a lot of pizza for 6 months in a row, this is going to help maintain that spring arch in your foot. That's going to help protect pretty much your foot, knee, ankle, all that good stuff. Okay, a lunge. All right, so I really like a lunge because it's gonna show you this asymmetry in your body. As you do these lunges, it strengthens a lot of different muscles too, which is really why it's such a good exercise, because it's gonna get your quad, it's gonna get your hamstring, it's gonna get your glutes. But as you do the lunge, you also really wanna be very mindful and careful about your biomechanics. And again, we're just kind of teasing out where we're weak, where we're strong. But if you're lunging and your knee is like trying to run over this way across your body, that's a really good sign that you have a weak glute medius and that we need to work on that. I also have noticed that for myself, when I do a lunge with my left leg forward versus my right leg forward, for whatever reason, my brain just only wants to use my right leg, whether it's behind or in front. And so because I know that, I can really mentally focus on making sure all of this is contracting instead of my right leg doing the work. But if you do a bunch of lunges and you find that your legs are sore in an asymmetrical way, again, that just shows we need to rotate that pelvis a little bit better. Maybe your right part of your pelvis is rotated, but your left isn't. But we'll even start seeing some patterns emerge when you do a lunge or any kind of like unilateral strengthening exercise like that. But lunges are a really efficient way to get strong, especially for runners. And then a good old squat. Everybody loves a good squat. Squatting, again, you gotta have to be careful with it. When if you start squatting and you see yourself drift, again, my right hip is a lot tighter than my left. So when I squat, especially if there's like a barbell on me, I'm not very strong. But if you add weight, you'll start to see these little biomechanical issues kind of pop up a little sooner. But as you do this, it's great to do a squat in the mirror because you want to make sure that your hips stay nice and square. You're not shifting your weight from side to side. Your knees aren't buckling in at the end. But if you don't know how to do a proper squat, step one is to actually learn how to do a good hip hinge, we call it. So the verbal cue that I like to use with my patient is, you've got an arm with a kid in one hand and a bag of groceries in the other, and you've got to shut your car door without dropping it. What do? Boom. You use your butt. You pop that butt out. So that's step one of a squat. You also want to be mindful, keep your core tight. Your sternum really shouldn't change angles as you go down. So use your breastbone as a gauge too. It should stay kind of nice, straight up, parallel, but you're gonna close the car door and then keep lowering yourself down. So close the car door, keep lowering yourself down. If you do have a lot of knee pain, a lot of weakness, you don't even need to go down quite as far. You can start out with doing a little half squat where you really just kind of close the car door and then squeeze your glutes to come back up. I guess that's another important one. When you come back up, squeeze your booty, squeeze the booty. All righty. Okay, boy, let's see. Chris, should we answer questions first? Are there questions?
We can. So we actually have one of the questions come through that says, what if it starts to hurt when you stretch and you can't hold for 30 seconds?
So that is absolutely okay too. Really, if it's painful for you to stretch, ultimately that tissue is not ready to stretch. So if you're having pain with stretching, really you actually kind of want to strengthen that tissue first. I like to use my hip flexors as the example. When your hip flexors when I have a patient who has really, really weak hip flexors, I actually want them to stretch their hip flexors. So here, let me back up. Here is a muscle. Here's a fully stretched out muscle. Here's a fully contracted muscle. We operate our day-to-day, even if you're an Olympic athlete, you're really only using 80% of that contraction range. If you sit a lot, for example, and your hip flexors learn how to be really tight and short, suddenly that contraction range is a lot more narrow, and that can lead to pain in the muscle and weakness in the muscle. In order to actually neurologically let this muscle finally relax so that it can get into its full contraction range when there's pain involved, it's actually better to strengthen that muscle just a little bit before you try to stretch. When you actively strengthen a muscle just a small amount, like we do, and I'm talking, it doesn't take much. For hip flexors, I'll literally have my patients just kind of gently push their hand into their knee, hold it for about 10 seconds or so, and then gently start to stretch it. So try that, because neurologically, when you lightly activate a muscle, when you very lightly strengthen it, your brain kind of goes, oh, okay, well, we're contracting the muscle. That muscle's okay. We're fine. Okay, now we'll relax. Now we'll let you stretch. If you don't contract that muscle first and you just try and dive straight into a stretch, that irritated, pissed off muscle is like, wait, no, we don't want to. And it'll start to hurt and it just won't relax. So if you have a group of muscles, a lot of issues like upper trap here, hip flexors, people will be like, I stretch every day and it won't release, it won't relax. I use my lacrosse ball every day. That's because that muscle is weak and it's essentially clinging on for dear life going, no, I'm too weak, I can't do it. So it will start to become tight and painful because of weakness. I hope I answered that question. But if it's still painful, even after you do a little bit of a contraction of that muscle group first, so if it's like your plantar fascia that you're trying to stretch, you're actually gonna like curl your toes really tight, then try to stretch it. If that's still painful, that's another one of those issues where you should definitely come in. We'll take a look at it. We'll tease out some of these other biomechanical issues and then figure out where that pain's coming from.
Thank you for that. So the second question that we have, and then we'll finish the rest of the presentation, was, so whenever you're doing a lunge, which leg do you use to get back up? Do you use the front leg or the back leg?
Ooh, good question. It's actually a trick question. And it kind of depends on if you're doing a reverse lunge or a forward lunge. And really, I personally do a lot of static lunging here, but if you want to kind of figure it out, anytime that you are shortening a muscle, that muscle is doing some of the work, but at the same time, like lengthening a muscle, that's more control. The actual lifting, the power comes from a contracting of the muscle. And so when you're going in a down phase, see, this is also why it's a little tricky, because if I'm going down into my lunge here, I've got eccentric contraction of my quad, but I've also got concentric contraction of my glute. And so really all you want to do is just, a yoga teacher taught me this verbal cue: hug your muscles to your bone. And that is how you're going to pull yourself back up. So you want to go down in a just really slow, controlled way. You don't really have to think about your muscles when you're doing that. Just lower yourself in a controlled way. You don't just want to flop down. And then as you do this, squeeze all of your muscles into your bone. But if your right leg is in the front, you're using your right glute to lift. So that's what I would say is focus on, if you're going to think of a lunge as a workout, focus on it as a glute workout, even though you're getting the benefits of other muscle groups. But the leg that's in front should kind of do most of the work, especially on the up phase.
That was a perfect answer, Dr. Westbrook. So if you guys have any more general questions about anything Dr. Westbrook talked about, for sure send those over to us in the chat function, and then we will get to those at the end once I go through the last few couple of slides. So for those of you who are familiar with Airrosti, some of these statistics will look really, really similar to you. But for those of you who aren't, all the things that Dr. Westbrook talked about in the presentation, like the actual diagnosis, understanding how the different injuries might come up and how you can be preventative in their care, these are the statistics that we come up with. So basically helping us stay accountable to our patients. So like we said at the beginning, number one, whenever you come to Airrosti, we want to make sure that you're in the right place and that it is something that we can take care of, whatever you're dealing with. So because of that, that's why we only have to see our patients about 3 to 4 times, because we look at getting to the source of your pain and then resolving that pain while you're in our offices, and then teaching you how to do that same thing whenever you get out back into the world. So because of that, we've also been able to avoid over 16,000 recommended physician surgeries. And a lot of our patients have come to us after they maybe got an MRI or an X-ray over a specific injury. They might have seen a specialist or even gone to traditional physical therapy or chiropractic care. So like we said, we want to make sure that you're in the right place and that we can get you to that full recovery. And 88.3% of all of our patients would report that they've been able to get totally out of pain. And because of that, 99.5% of all our patients would recommend us to family and friends. And so today, Dr. Westbrook talks specifically about some injuries that we see that pertain particularly to running and some walkers. But we see a wide variety of injuries that come into our clinics. It could be something acute, maybe like you woke up with some neck pain from sleeping wrong. It could be an ankle sprain that happened yesterday, or it could be something chronic in nature that has been going on for months, weeks, or decades on end, maybe like some sciatic-like pain, maybe some carpal tunnel because a lot of people are at their computers typing a lot, and things of that sort. So, and lastly, Airrosti is an in-network benefit for all of Austin ISD's health plan members and their dependents. You don't need a referral to go see any of our providers. We have over 30 locations in the Austin area, and Dr. Westbrook's location is literally right off of Red River at our Airrosti Red River office. All of our clinics are currently open and making sure that we adhere to the recommendations of the CDC to not only provide a clean and a safe environment for our treatment teams, but also for the patients that go in. And lastly, I would like to thank you all again for joining us for the last webinar of the year for Austin ISD. If you have any specific questions, like we said, you're more than welcome to. We definitely encourage you to scan the QR code and maybe schedule a time to talk to one of our providers directly in the VIP chats, or you could also visit the website at airrosti.com or the 1-800 number. So Dr.